We get a lot of razzing as oncologists as we get down lines of therapy with metastatic pancreas. These patients are occasionally getting admitted to the hospital. They're needing more palliative care. What does one do with that sort of failing PS pancreas patient who still wants to try something? Are there things that are out there that may be not eligible for a clinical trial, or is this a patient where the nihilism starts to actually play in? It's a hard question to answer, but I'm tagging you with it.
California. I'm not sure what California part comes with this, but yeah, this is very challenging.
You guys are better.
Never sit on the right side of John.
On one hand, I think that it's a tough, difficult question, but it's just interesting that it's questioned at all, because I mean, just in terms of how old, it hasn't been that long. We've had the option of having multiple lines of therapy, and I think it comes in some part. We've been discussing about deconstructing and whether you have 2 lines of therapy or 3 lines of therapy. If you start with Gem/nab-paclitaxel, you go to 5-FU and liposomal irinotecan. You do still have the option, I think, consideration of 5-FU and oxaliplatin, and so I think that that's something to consider. We don't have high-level data, but it's something to reasonably argue that it's a component, active therapies that we could still incorporate. I think the challenges of what you're asking is that, I'm going to turn it around, is how many patients actually have a suitable performance status at the 3rd line, even the 2nd line, to be able to go on to additional therapies. I mean, I think that's true for clinical trials too. You can't go on a clinical trial with a performance status of 3, right? So it's true for standard therapies as well. And so I think if we can get some benefit with monotherapy, I think those are things to still consider.
Yeah, I just always worry about the fairly sharp decline in pancreas cancer patients too, but I totally agree with everything you just said. Yeah.
I think they exist, at least in New York.
Yeah.
There are patients who are 3rd line who really have no obvious treatment option, but are fit enough to get treatment.
Yeah.
And they want to go on phase 1 clinical trials. There was a study actually here at ASCO from the Memorial Sloan Kettering group about those patients going on trial and almost none of them having benefit because there are no agents, really, almost no agents. But when we do trials, the patients come out of the woodworks and we find 3rd line trials. However, the majority of patients are not boldly going to 3rd line. They're struggling. And I think it's really not in their benefit to give them toxic chemotherapy when they're not performance status 0 or 1 and able to handle it.
Yeah, I mean, it was just, there was a time when almost every patient with a metastatic GI cancer got all the known therapies because we didn't have that many. And so now more and more, at least in my practice, there are patients who are not getting all the therapies because of this. And so I always struggle with, trying them to see if it turns somebody around versus worrying that I'm not going to have enough time in this patient population. It's a challenge.
I want to say in the BRCA subset of patients, though, I do tend to try, if the performance status is 0 or 1 still, and sometimes we do see that, try to add in mitomycin, irinotecan combinations again. So I think we can rescue maybe a few patients here or there using that approach. So Paul, have you done that?
We've done it very occasionally, and it's toxic. I think the BRCA mutated patients or the surrogate, the ones who did really well with FOLFIRINOX.
Right.
We don't know if they're BRCA mutated.
Right.
They'll often be able to handle more lines of therapy and alternate therapy and go back even, or mitomycin.
This subtype, I mean, I think we all have in our patient populations that often it's a little old lady who, with pancreas cancer, who's living 2-3 years with metastatic pancreas cancer. And there's clearly this subtype that is much quieter. And you don't find that subtype unless you treat. And often it's that older, frailer patient that's the one that's going to stick around for a while.
You're right. I mean, it's definitely, there is a subtype. So, lung-only mets is a definite subtype in pancreatic patients who tend to do better. I think the BRCA subset. There's also a BRCA nest subset. If they have more, they have family members, they may not have the germline mutation, but they have, if there's a 1st-degree family member. So I think there are definitely these patients who are out there. I do think, you just have to look at the 3rd line. You just have to look like parameters. Albumin is a big one. If they're getting frequent taps, peritoneal disease. So you can look at those patients who would benefit. And I do think in the ones we don't think they would benefit, I think supportive care that, we start them early, the supportive care during frontline treatment when we're giving them. We always have our supportive care group follow them also with us. And because I do think that really improves the quality of life, and then that transition can be a little bit easier. I think they do benefit from that early initiation of maybe supportive care hospice if they're truly headed in that direction.
Absolutely the worst part of our job, but maybe the most important part of our job, and the one that makes it hard. It's a hard job we have, and knowing when, how to coach that patient, and supporting them not only as palliative care docs, because much of what we do is that, but also their coach, their life coach and psychologist as we go through that.